Welcome to the Pansa Pansa Forum. In the Yoruba language, the word pansa is usually injected into poetry to express an uncomfortable, uncensored, and inconvenient truth. The Pansa Pansa Forum is candid conversations about the life of African immigrants in America as it relates to their adaptation to their new home. While some may find it easy to integrate and can balance between retaining the original African culture while accepting the culture of their new home, many continue to struggle to find a balance between both worlds.
Hello and welcome to Pansa Pansa Live. This is a podcast where we discuss the lives of African immigrants and their assimilation into Western society as they raise younger generations in a country that is quite different from their own. We also explore the experiences of children of immigrants as they balance the African and Western cultures. We present to you this informative, interesting, and expansive dialogue about the intricate experiences of African immigrants in America.
Okay, welcome to Pansa Pansa. I'm your host, Kemi Seriki, and today I am honored to have conversation with a fellow podcaster from Nigeria, Dr. Motolani Ogunsanya, the host of the Most Civil podcast. Dr. Tolani Ogunsanya is an assistant professor in Department of Pharmacy, Clinical and Administrative Science at University of Oklahoma Health Science Center. So welcome, Dr. Ogunsanya.
Thank you so much.
And thank you so much for coming to this platform. I'm so honored to get to know you and to come and talk about your experience as an immigrant, the selfless work that you are doing on your podcast, and to also talk about cancer cases in Nigeria and the care available to cancer patients in Nigeria in general. So as I always ask my guests, I know I did the introduction, but fully introduce yourself, talk a little bit about your background to our audience as to where you were born, where you spent most of your childhood and adult life.
Okay. First of all, thank you, Ma. The honor is actually mine to be on your podcast, and I know you do great work. It's just been great knowing you so far, and thanks for all you do for our community and for also showing us, so many ways of bringing people together. So thank you, Ma. I was born and bred in Lagos, Nigeria. Come from a family of 5, 3 kids. I'm the eldest. I have 2 brothers. Came from very humble beginnings. My dad was a trained banker until he retired many years ago. And my mom was a trained civil engineer before she became an entrepreneur. But growing up with the limited resources, because my parents were first starters, as a matter of fact, my mom had me, and I want to use this word carefully, out of wedlock, but that's the only way to explain it so that people can get it right there, because nobody uses that anymore. So I mean, that she came from a very ultra-conservative family. It was a huge initial, it took a lot of adjustment for her family to kind of, get settled around that idea, because they were kind of worried for her not being able to go to school. But she would end up going to get her engineering degree, and she had me, and then our family was from. Mm-hmm. So I grew up in Lagos and then went to school, went to Federal Government Girls College, Oyo, as a boarding house student. Got into the University of Lagos to study pharmacy. I'd always wanted to be in services of people, like doing something that had something to do with people. It was either medicine or pharmacy, and I just struck out medicine. I don't even remember why. But pharmacy just became, I know why, because there was a chemist in front of my house growing up that would give me vitamin C. And she was always dressed so prettily well with a coat, and it was always AC. I didn't grow up having AC in the house. And one time I had a very bad cold, and she gave me Contact, which was like a gel, like a capsule that had colorful gels in it.
Yeah.
And it made me feel better. It was almost like magic. I'm like, wow, I can dress this nice. I can have all the access to vitamin C, all those, or not the white vitamin C, the orange nice ones. Not say vitamin C, because I have a sweet tooth that lured me into the pharmacy profession. And so, after pharmacy school, I worked for Chevron, and then I worked for Harvard PEPFAR, I'm working with patients with HIV/AIDS.
Wow.
And I started to go to grad school, realizing that I needed to know more about the social behavioral aspects of adherence, especially when it came to communicable diseases like HIV. So that pushed me to grad school and, got my PhD and master's degree at the University of Texas at Austin before transitioning to my role as an assistant professor of pharmacy. So, yeah.
Wow. All that accomplishment within no time.
It seems like that because they're just rushing through a podcast, but there were moments of doubt and frustration in between. So it wasn't quite as easy as I put it out.
Of course. And how does it feel like being a firstborn in your family?
How does anyone feel? It's not like you chose it, So they're just natural born leaders. In fact, as a matter of fact, I was telling my guest today, who's also a firstborn, there's just the way you move differently. And in fact, that was one of the worries I had because my husband is the last born of a family of 7, and I'm the first. I'm used to telling, I'm the commander of my ship. I tell my battalions to go, they go, they don't question me. And then you being the female, right? The way the role is traditional marriage role, the husband is head. So having to adjust that, I don't want telling me what to do. So that was one of the biggest issues we had in the early stages of our marriage. But yeah, I don't feel pressure to move a certain way or like be an example to my siblings.
Yeah.
I think by virtue of being the first, I always want to strive to make sure my path is one that is clear and not full of anything bad or evil or illegal or things like that. Yeah. So I think maybe natural disposition, but I don't feel any pressure. My family they don't talk about the firstborn. She said my parents have never said that to me.
Yeah. And that is so great to speak about. And that's very great that your parents are able to follow through that path and understand that everybody's path is different.
It's different. Yeah, never heard them say that. In fact, the times I would hear it will be in TV shows or when people mention it, but never from my parents' mouths. Never did that. Yeah.
Yes. So it's something. So, and I know that many immigrants left their individual countries to migrate to another country for their lives. And as a student, to for many reasons, to obtain education because of civil war. Because I like to talk about this when I talk about immigrant coming in. People just think that people left their country for anything, just on vacation. But there's certain situation why people left their country. There might be war, there might be, all kinds of conflicts, or to escape poverty, or to find new economic opportunities and employment. So what would you say the reason for you to migrate to America? Why did you choose America?
You know what? I wouldn't have known why, if not for the people that surrounded me. The way my friend explained it was that you were born in the wrong country. Because you were just never, the way you talk, the way you think, even despite in environments where, because I grew up very humble, my parents didn't have a lot of money. Yes. Like I said, having me out of wedlock and having to start their life. And how most Nigerian homes are, there's no intergenerational wealth to fall on. So they had to be for starters. I think for me, whenever I started practicing as a pharmacist, I knew there were some things I didn't want to keep doing for a long time. I didn't want to be a community pharmacist for a long time. I had gone through rotations and internships. I realized the impact of it, but the way it was being done, it felt very prescriptorial in a way, like you're just counting medications. That was just my way of looking at it, even though I know there are many layers to it now with people being more engaged in their community. But way back then, it was just counting pills, and I didn't want to do that. I get bored easily. If I'm not using my brain, I'll actually go into a state of depression. That's how I am. Wow. So even moving to working with HIV/AIDS as a specialty pharmacist was my way of just taking up a challenge, because those are complex cases you're managing. And I love that challenge. So that was the best times I had was actually in rural settings, which was where I was in Ibadan, working with PEPFAR, UCH, University College Hospital. But I realized that this was it. There was nothing more anymore, and I wanted more. But I think that was what drove me to grad school, because I realized that if I had stayed here, and when I was even working with Chevron, the pay was good. I was earning way more than most of my peers were earning. But I realized that even if I kept at this pace, I was going to get almost demotivated with it after a while, and it wasn't going to be what I wanted to do. So I've always been looking for a way to satisfy that longing. I just didn't know what it was. I was very restless at the point in Nigeria. I would wake up not being able to go back to bed. It was always nagging at the back of my mind that I wasn't living up to my full potential. And then I didn't want to write the GRE, which was a graduate record examination, to get you into school in the US. Because I was I've been out of school for 3 years. I don't want to start studying for math and English. So I just lazily applied for schools in the UK. And within a week, I got 2 offers, right? Wow. I even got £5,000 off one of my scholarship. Wow. I think it was for Aston University to go and study drug delivery. And I was going to take it up. But I remember a roommate of mine telling me, I don't know why you're just cutting yourself short. If I were you with your degrees that you have, because I finished with a first class in Unilag, like I would go for the best. Like, don't is it GRE? Is it means to an end? Just study for it and forget about it.
That's
and for
right.
the first time, it just something snaps in me. Like, really, GRE is just a means to an end. It's not like I'm gonna take GRE for the rest of my life. So I had the textbooks, dusted the dust out of it, and then picked it up and I started studying. I think for me, it was just knowing that I owed it to myself to always pursue excellence, right? And it's how I've always been. And I know my parents also, instilled that in me. And leaving Nigeria to seek greener pastures also was because I was wanting something that Nigeria wasn't giving me then, and which was to be able to compete globally on a stage, but given the right opportunity, given the right tools. I didn't want to be in front of people where I felt like I wasn't well equipped. So I wanted to give myself an opportunity to be the best at my craft, and the US offered that.
Yes, of course. I mean, this is the greatest country in the world, even though there's so many.
I know, there's so many layers we can dissect on that. Yeah.
So Nigeria and other African countries are losing talents.
Sadly.
Like you, most educated member of the society, in most important fields, such as yourself as a scientist, doctors, engineer, many more. Who would have actually contributed to, development of that continent? What is your opinion or your view of this migration of brain drain?
You know what, Ma, I'm part of the problem. I'm not gonna lie to you, we're part of the problem. But I also think that the solution lies within us. But there's so many things about the brain drain as a whole that we need to really address. And I think the biggest thing is the push and pull factors, right? For brain drain to happen, there has to be something that is pushing you out of your low resource country and then pulling you towards the high resource country. And I think the biggest thing in Nigeria is just the poor infrastructure. We're never short of talents. We have great minds, Nigerians doing great things everywhere. So the migration of health workers like brain drain, it's in search of better standard of living and quality, higher salaries, access to advanced technology, and more stable political conditions in these different places of the world. This issue, emerged first as a major public health issue in the 1940s, where, many European health professionals were immigrating to United Kingdoms and the US. So by the mid-60s, the losses were enough to cause concern. And I don't even know that, if you know now, recently the UK, WHO had to place a red alert to stop the migration of healthcare workers from Nigeria to the UK. Did you see that news recently?
No.
Yes. They're going to be limiting doctors and nurses and other ancillary healthcare workers because now we don't have enough people, right? So there was a report survey that was done many years ago. This was a survey in Nigeria. They showed that 8 out of 10 medical doctors, representing about 88% of medical doctors in Nigeria, are currently seeking job opportunities abroad.
Yes.
And the MDCN, which is the Medical and Dental Council of Nigeria, they have about 35,000 of them within the members in the nation. They found out that even if, that many people have, migrated out, they've left. And if the way the Nigerian politicians are responding to this is to start talking about bonding. They want to bond medical doctors down so that way you can't leave the country after your school. I get it. Our tuition is so subsidized in the sense that it's a loss to them that we're going to school for almost next to nothing. But then by the time we're trained, we leave. Most of us don't want to leave.
Yeah.
I'm never going to be Nigerian. I'm never going to be American enough here. I'm always going to be an outsider.
Yes.
There's a grief that I carry, not being with my family. We had a death in our family last year. We couldn't be there. My husband couldn't be there when his father passed away. Wow. So these are some kind of things that we are faced with almost every day. We're not 100% at home here. Yes. We want to go back home. We want to be with our own people.
Yes.
That aside, here's the paradox. Now, compared to the US, where people have to pay through their noses and, with enormous student loans, medical training in Nigeria is highly subsidized, because the government has made it so. Yet, those doctors that are trained, with public funds, are taken by other countries because there's value there. And this is why I think in addressing the issue, it's not to be bonding doctors down or medical professionals down. Mm-hmm. It's improving the conditions, the working conditions, the living conditions to be able to thrive. My husband's cohort, when he finished medical school, because my husband is a physician, okay. I would say maybe 8 out of 10 of them have left the country.
The country, can you imagine?
With one of the recent one being a plastic surgeon. Do you know how many of them are in Nigeria?
In Nigeria.
Not so many. Not so many of them in Nigeria. And he was there for a while. but not for his kids in particular, but I've heard of people not being able to afford school fees for their kids because we're being owed salaries, right? Yes. Now, according to the WHO, for any country to be deemed to have enough doctors for its population, it should have one doctor for every 600 persons. And I'm using doctors because, that's just like, a good example to kind of contextualize this problem. That means that Nigeria needs more than 275,000 medical doctors to meet WHO standard per the doctor-patient ratio. Yes. We don't even have enough doctors. If all the doctors who were trained in Nigeria came back, will only be about 30% capacity. So we're not even training enough doctors, one, and of the ones who are trained, they are leaving. Why are we leaving? Why are we leaving our families behind? Like, I have a daughter now, and I'm beginning to think about just that family bond. I'm having to create a pseudo environment for her to understand what community is. And I'm sure as you know, here it's so anti-family. Yes. The US, with the downside of capitalism is that everything is almost transactional. Yes. So it's a lot of added pressure. We have to rely on WhatsApp calls and FaceTime to be able to connect with grandma over the screen. Her grandpa died last year. My husband's father passed away. And she only met him once, and she would never remember because she was like less than two when she met him, and just said hi and walked away, and she was busy with her toys. She would never have those interactions. So those are some of the issues. A lot of us abroad, there's that grief for carry for being away from home. Yeah, we live in fancy houses. We drive, cars that have car notes on them. We were eating good food. We're able to dance on TikTok. But there's a grief for carry, not being able to be with our own people.
Yeah, it's a great loss. And the government, you have to be able to build infrastructure to allow people to stay. Safety is also important.
Yes.
For people.
And to be able to beat it, because you can have all the money in Nigeria. I had a friend whose mom died on the way to the hospital. She had a cardiac arrest, and the ambulance made it to their house in Lagos. But to get out of their house, their estates, they were stuck in traffic.
Yes.
And she passed away.
And these are many of these leaders who come to Europe, they come to America.
For medical care.
For medical care for themselves and their family.
Yeah.
But you are not looking at the population in itself.
Yeah. So I think the solution is actually a top-down approach. It has to start from policies handed and implemented from those in leadership. Mm-hmm. So for countries like ours, Nigeria, that's quite developing, we need policies that have deep-seated nationalistic base. Mm-hmm. And it goes beyond just increasing salaries, because if we were to do that, inflation would, tag along with that. Yeah. So I know the National Health Act law that was passed in 2014 in Nigeria, I think there's section 11 of it that says that 10% of the basic healthcare provision needs to be spent on developing human resources for primary healthcare, which is, not quite as robust as the 2001 Abuja Declaration, which promised that it was going to do 15%, but that's a story for another day. But we also need to take some practical steps. Take, for example, the British government in recent terms, they've started doing some things to discourage medical workers from migrating to Britain, right? Especially Commonwealth developing countries.
Yeah.
They started, and I think a third one, which might sound very counterintuitive, is encouraging more brain drain.
Yes.
But here's my argument for it. Now, one thing that is missing from all these Nigerian brain drain stories Tagawa was talking about is how much money Nigerian immigrants actually send back home.
That's right.
They are contributing to the economy.
That's right, because many people depend on that.
I have never met a Nigerian that doesn't send money back home. I have never. Mm-hmm. I'm yet to meet. There could be some, right? Maybe they don't have family. But this is just what we do.
Yes.
When we pay our tithes, we're sending the rest back home, right?
Yes.
And so we can encourage brain drain as a temporary solution. For this to work, there has to be transparency in public governance.
Yes.
And instilling in the public that Nigeria is a place worth fighting for.
Yeah.
Meaning that my re-entry into the Nigerian economy has to be incentivized and not seen as a regression. Because if you leave the US now and come back and be like, what are you doing here?
Mm-hmm.
And there was so that's why I mentioned that the MDCND, the foreign majority of Nigerian doctors, about 87% of them, said that they believe that the government is unconcerned with mitigating the challenges facing medical doctors in Nigeria.
No, they are right. They are
very correct.
They are unconcerned because when you have the population, most of your population are young age.
Yes, and Africa is the youngest in all of the other continents. We have the youngest growing population in the world. And that's human capital right there.
Yeah. But then the life expectancy is between 45 to, maybe 50 or 60 or something like that.
Yes,
even
ma'am.
to the extent when you reach 70, whereby when you look at a 70-year-old in America,
it's different.
I don't even believe that they
it's
are
different. It's different.
Because
it's
they
different.
get, some form of care that is supposed to be available for every human being. So this is the sad part. When we talk about Nigeria or any other African countries, they are not investing in human capital.
No, not enough.
They are not really thinking about how do you sustain the society. The only thing they talk about is sustaining their own pocket.
Their own pockets. And let me even add this, man. Like, we have a lot to be enviable about. Look at countries like Japan or Korea. Their population is dying, and birth rate has, reduced significantly. By 2050, the population of Nigeria is supposed to grow exponentially because, our birth rate is one of the highest in the world. Yeah. As a matter of fact, we've surpassed India as the poverty capital of the world. Yeah. Now, when I talked about that reverse brain drain, I wanted to give some examples of how it's worked in the past, right? Mm-hmm. In Korea, it has worked. So sometime in 1963, about a few hundred Koreans left Gimpo Airport. They were the first batch of Korean miners. They were sent then to then West Germany. Mm-hmm. Now, by 1977, about 7,000 miners, including 10,000 nurses, were also sent to Germany. This was when Germany was a country that they had known little about, but they included graduates, included dropouts of prestigious Korean universities. So there was a memorandum signed between the Korean government and the West German government in saying that we'll provide you labor, but you provide us money. So for every person that was sent, the West German government paid Korean government some money from that. Now, in these countries, you have Koreans who have stayed there. Yes. Some of them, they call them Koreans. They're just, they're Korean nationals in other foreign countries, but they're registered Koreans, Now, at that time, Korea was a country whose per capita income was at the bottom among a lot of other countries. College graduates, though they might have that high status, they couldn't land any job, as there were very few corporations hiring them. Does that sound familiar? Like our countries, right? Yes. Now, being born in a poor country forced those with a high level of education to volunteer to work in doing jobs like, cleaning courses in the hospitals or working in coal pits in foreign countries. Now, these miners and nurses were the first lot of Koreans who went abroad to make money after the country was liberated from Japanese colonials in 1945. Mm-hmm. Now, their remittance helped to build the economy up. Yeah. Nigerians are already doing that. And all of the sacrifice of these highly skilled workers, they've emphasized this thing we call Miracle of the Han River, which is referred to the period of rapid economic growth in South Korea following the South Korean War, Korean War. And it helped the nation to achieve the goal of industrialization and democratization. And it prevented it from regressing, to other kind of means. The government can encourage that. Now, when these people came back, they were put in positions where they could use their skills. Mm-hmm. They had drivers provided, they had good housing, they had good, working condition. Mm-hmm. If I'm living here now, what I have, and go back home, what am I going to? Yeah. Unless I see God descend from heaven and say specifically to me, and I see his lips moving, what will make me want to live here and go back home?
Go back home. Yeah.
So these are the issues. We know there's a problem with us living, but there's a reason why we're living. We're leaving our families behind. We're leaving our structure behind. We're leaving our foundation, our roots, our effort, our culture behind to start over again.
And that's one thing they are not understanding. Like I said, everything has to do with many of these politicians and also the society in terms of our value system, who we value.
Yes.
We kind of value people because of their material wealth.
Looking up to them for the wrong reason.
Not actually thinking, not actually looking at people who are actually doing something to improve the society. Our value system have really changed.
Look at the last election. You don't have to even look for that to drive home that message.
And we are losing the essence of our cultural heritage in terms of the value that our culture these teachers, according to the Yoruba, there's a saying Ashonla kole yonla. Just because you wear fancy clothes does not make you an important person. Because what you do to humanity of others is much more important than the material wealth that you tend to possess. Is to challenge.
Yes.
Just because you have a humongous house or you have all this material wealth does not mean I'm really impressed about you.
Yeah.
In terms of your material wealth or in terms of your political career or whatever it is that you possess. So we have to start changing our mindset towards that. Because
I agree.
That's why we have a lot of all these issues also going on.
And I think those kind of behaviors, they move along. I think I tie them to a poverty mindset, where it's just instant gratification. And that says a lot about the reflection of the economy, where the people tend to worship the most are those that have money. If money is the pulling factor, then that's, to me, an indication of a sick society. And I think with exposure and just modeling what proper thinking should be like, I think with time, maybe people will catch up. I don't know.
Yeah. We have to change that kind of mindset in terms of, I call it egocentric on nothingness. So it's something that we need to change, that kind of mindset among the people back home, even among our community in America here, or, all over the world. So thank you so much for that. It's so much that
Of course.
So what would you say, since you've been in America, what would you say are some of the challenges you experienced during your early part of being the new immigrant in this country, early part of your time?
It was so much, man. For context, I moved here in my 20s, which again, some might say was early, but I don't know, whatever can be made out of that. But because I also came here for a purpose. I just didn't maybe come here on vacation and then wait behind, or came here on a green card. I came here as a student. I actually came a week after classes resumed. No, I think 2 days before classes resumed. So I didn't have enough time to kind of like settle into it, and having to like battle reverse jet lag and all that. But I think the educational system was the biggest adjustment for me.
Okay.
And because where I was taught was you're given what to say. You don't challenge your professors. You're not allowed to think outside of the box because it's uncomfortable for them.
Yeah.
But I knew there was a part of me that was just dying to come out, because I had a lot of questions. I have a lot of things I didn't agree with. But of course, you couldn't voice those concerns in class because you're just going to be red lettered and then get into trouble. So coming to a space where in grad school, for example, your portion of your grades will be towards discussion, you saying something in class. It's not about open book test anymore. How do I develop an argument? Like, sir, I wasn't taught to argue. I was taught to just follow orders. I know there's something in there to say, but it's not just coming out of my mouth. My brain is forming the words, but I can't just speak them out. So I struggled like the very first semester. And I'll look at my counterparts, my American counterparts, the way they would just talk. Even when they're making arguments against what the teacher is saying, the way they will say it without being offensive, I'm like, wow, that's that. How'd you learn that? Like, when the textbook, what page should I turn to learn that skill? So I started observing, I started looking at them. I started being part of their conversations. And I realized, so that's how you do it. So I remember the first time I opened my mouth in class, we're talking about healthcare system, because I took a health policy class.
Okay.
And whatever I said was, of course, arguing against the professor. But I thought, like, by the time I was like, this is the day they're going to pack my load and call immigration, come and kick me out of this school. I have done it. I have challenged my professor. I'm done. I'm graduating today without degree. So I went to meet him. I was like, hey, I'm so sorry. I felt like, the way I talked in class was not appropriate. He was like, you know what? I've seen your write-ups. You write so well. You have such a brilliant argument, but I've always been hoping that you open your mouth and say something in class. Those were very interesting points, and see how your classmates responded. As a matter of fact, do you want to come talk, more about this over coffee? Let's pick your brain on some ideas you might have for your research paper. And by the way, call me. He said I should call him by his first name. I'm like, sir, hold on. I'm not calling you by your first name. That's one. But you're serious? I'm not in trouble. Like, no. Why should they be in trouble? This is grad school. You're supposed to, express your opinions. And that was it. That was what liberated me.
Wow.
The educational system adjusting to it was very difficult.
It is so wonderful the way you bring this view up, because even many of our children who were born in this country, growing up in African immigrant home, do experience the same thing. When they go to college, they don't think that they have an opinion or anything to say or argue back. And that couples with the lack of exposure to other community in general, maybe in this country, everybody is so divided along the racial line, along the ethnic line. So it does not actually give so much chances to expose yourself to other community of how they are doing things. So that is so interesting. And since then, you can't keep quiet anymore.
Oh, no, that's why I grew so huge balls. I now work for university. So you can imagine just how That confidence boost was so great
Yeah.
for me.
Imagine in Nigeria if that is allowed.
Oh my goodness. Because we're so smart. I mean, look at us. I mean, for you to qualify to get into, I went to UT Austin, which is one of the top universities for my degree, and it's well renowned. For you to get into that as an immigrant, as an international student, you were taught well. There's something you're doing well already.
Yeah.
So, and then you're competing with the best of the best, because graduate school is a hyper saturated pool of very smart people. And I started realizing that, my goodness, that was me being a local champion. That this man, I just had to just shed my local warrior mentality. Like, let me just pour myself out. I know nothing. How can I start filling myself in?
That's right.
And I think the mistake we also make is that we don't make use of our TAs, our teaching assistants.
Yes.
I learned you have to mix with it. So when I was, because I schooled in a university that had majority white people, just because of where Texas was, but it was also quite diverse. I'll give it to Austin. But a lot of my friends that we studied together were mostly white, and there's a way they did their teamwork. So from then, I learned how to use Google Notes to kind of like everybody put in your thoughts, and let's create like study sheets to like, talk about some points like, study for the exams. So working in a group to kind of like do things together. I didn't learn that in university in Nigeria because everybody just put on their own. You just hide your paper, so that way you can pick the other person and move top and become first. It was always like a struggle mentality while I was in Nigeria. But here it was very cooperative. Without you, of course, like you're cheating. You're just trying to find ways to study together and be together. And they're always going for TA hours.
Wow.
Before the class is finished, they're already emailing the TA. We would like to see you for this and that. So I will tag along. I'm like, and the TA will explain it better, sometimes even better than the professor did. So I learned how to use my TA. So this is just a tip for those that might be in school. You've already paid for it. Your tuition has been charged. Just use it. Use your TA.
And my children did that, both of them, when they were in college. Immediately, they will not only email TA, also meet the professor, because
Exactly. Don't just go. Exactly. Don't just go when you're having issues,
And one thing people are not realizing, when you are connected with your professor, you don't know who your professor is also connected with, and say, you know what, I think I might have a job opportunity for you. Or if you're going to grad school, this is another opportunity of some of my old students that you could actually meet, and they will be of a help for you. So it's a good thing. And I wish, back in Nigeria, we have things like this, going on. So I was reading one of your research work published on PubMed.
Okay. And which one of them?
You co-authored with other group in the field of dominance of health-related quality of life.
Dominance,
International students regarding their experience with acculturation, which could lead to physical and emotional distress.
Yes.
So, and this comes in a variety of settings, including in social, academic, or employment, as a result of difficulties in, different culture as well. Only if you are among those groups, such struggle may not be visible to you. If you are not among international students, you would not understand such struggle as well. So can you briefly talk about these challenges, this experience that is so common to foreign students in US?
I think foreign students were unique. Because whatever made you leave your country in the first place, which we talked about, which is unique to most immigrants, but then being in a school environment where there's a special kind of performance metrics attached to it. Not only are you being evaluated based on your own merits, but also relative to that of your cohorts. That is the added layer. And they're coming onto a stage like different from the one that you were, brought up into. So in addition to the stress you face in a highly competitive environment, like in a university or in a school program, but being that you also bring that sense of other outsider, that otherness that you bring also adds another layer of it. So acculturative stress is one of the big ones that study talked about. And whenever I put it together, this was actually one of my lowest points of grad school, because even as a scientist, sometimes passion is one way to kind of begin addressing a research question. But this was a pain point in the sense that I wanted to just showcase the importance of university, especially, or even programs, curating programs that can help support the international students. Now, students need to be supported regardless of where they're from, but it was very important that we highlighted the voices of international students and what they went through, And for stress, we're looking at things like physical stress and also for mental stress, right? Again, there are also some supports. So one of the big things I always say when I talk to my friends who are trying to migrate here is that no matter how big your university is, no matter how much they're offering you in tuition, as far as tuition waiver and all that kind of fancy stuff, if there's not an international office, right? And if there's not like an international office that is supporting you as an international student, don't go to that school. Because they serve as your liaison. Because what happens is that whenever they get their tuition and whatnot, some schools just leave you in the lurch, But international office, they speak your language. They know the pains about visa immigration. What if you start going through visa issues or you need somebody to advocate for you? Because I went through those issues as well. When I was in grad school, we had visa issues because all of a sudden our visas were canceled by the US government because they said we did something fraudulent. A mistake that they made, which we called them out of, was why they emailed us back. That's totally another story. But at that moment, if I didn't have my international office advocating for me and helping us troubleshoot this issue, I probably wouldn't be here today. So I think it was very important in that study to talk about just how international students face additional level of stress due to acculturation. And this can also impact how they even do well in school, and then if we use coping mechanisms, some people might have unhealthy coping mechanisms. Like for me, mine was through food, which also affected my health. Some might be through alcohol, some might be through unnecessary vices. So just acknowledging and even helping programs be more responsive to their international student population. That was why we did that.
Yeah, and some school may be actually making mistake that, let's assume we have some international student from China. But we also have Chinese children or second generation Chinese children in this school. They will be able to connect with each other. No, it's completely different. Because just like many African students also who come from different countries as well as an international student may not be able to connect with those second generation or the first generation children who grew up in this country and they are in university because the experience is different. There's a lot of disconnect over there. So I'm glad that you brought that up, and I was reading, I said, wow, this is so important.
Thank you. That was done. Oh my gosh, I forgot about that paper. So to show you just how, because this was like 10 years ago actually.
Because you write so much.
Yeah, pretend.
You write so much. So let me bring you to your family. You recently marked 17 years anniversary since you met.
It's like my husband. 17 of meeting my husband.
And you said he is your rock, your best friend, and your soulmate.
Yes.
And you are both blessed with a beautiful daughter.
Yes.
And how have you been able to push through with the challenges as a wife, mother, and continuously pushing yourself ahead of your career in academia in a new country that come into, and the challenges of what it is to be an immigrant?
It's still a struggle. People talk about work-life balance. I don't think there's anything quite like that. I'm able to just say it's work-life integration.
Yes.
So for the longest time, it was just my husband and I. And I think it's just a miracle I survived those times because I was just doing so much. Like I was unstoppable. Nothing could slow me down, And your husband being, old enough to understand that there's work and there's work. So there was really sometimes no boundaries in that aspect because I like to get things done. And the reward for people like me is more work. You do work, you get more work. The reward for hard work is more work. But with a child, it kind of slowed me down. And initially, I wasn't very comfortable with that aspect of it because I was addicted to my fast-paced way of living. And it was also a bit ironical because it wasn't like, I came into motherhood like the conventional way. We came in through adoption. So it was something we sought out to do. Yeah. Not like, we found ourselves pregnant and this baby came to be. So I was telling myself, you wanted a child, but then you're not making space for a child, like make it make sense, And I just told myself, at the end of it, if I would prioritize one, I'll prioritize my family. Yeah. If my work will have to drop a little bit, which it has, but guess what? The drop it has is still maintaining its quality because the levels I was going before were humanly impossible levels to sustain. So now I'm at a natural pace where I'm able to do my work. I'm able to rely on my support staff to, bring out the beautiful aspect of my work. But it's also a blessing to model life, almost like I'm reliving my childhood through her. So I see like there are 3 streams that run concurrently with my parenting my daughter. There's my past self coming out, and there's my present self being mindful, and there's a future of what I would like to model for her to see. So the past self, my parents did the best they could. And as you can imagine, because they started their family overnight, they weren't very well equipped, but they did, like most parents, they did the best they would do. It's the same way my daughter might come on a podcast 20 years from now and talk about my shortcomings. And I hope she knows that, I'm not ever going to be a perfect mom, but I'll always do my best. Right. In also seeing how my husband is particular parents, it's a beautiful thing to see because I really didn't have that close relationship with my dad growing up. And seeing just, what a father's love, especially at a tender age. Myself and my dad are good now. We're very close, but I didn't have that growing up. But seeing that as a child is like I'm healing a part of me that was broken. And then the present part of it, a child demands your attention. You don't fit them in your schedule. It's the other way around. Yeah. And the moment I realized that, even though it was a very, very crippling truth to know, it made life easier for me. Like, you know what? I'd rather be a good mom, an average mom, than be the world's best professor. Because my legacy is not in my research. My legacy is in the people. Yeah. And if it comes through my research on my family, now that I have a family, especially a child that has been in my care, that's my primary responsibility. So I've had to reorder my priorities.
That's so beautiful.
And then the last bit is the future, right? I want to model what community is like for her. Right. And I think no better way than showing her just my struggles growing up as a child. I grew up a bit interrupted because I was abused as a child, and then moving here as an immigrant. And then she's also a different culture than I, those that have seen my daughter is phenotypically different from us. So having to just show her that family is not by the way we look, right? And you can always find community. So I used to worry a lot about fear of her being abused, the way I was abused as a child. It got me so weighed down, like wanting to just protect her from every kind of evil and all that kind of stuff. But I was comforted recently by God telling me that you had bad things happen to you as a child. There's no discounting that. But you also had great things happen to you because you've met great people, you met good mentors, you met positive people. So why are you worrying about things that, you're going to create the same environment for your child? There's no doubt about that, because I know you would. You can't protect her from everything, but you can surround her with people that are good. You can replicate mom and dad everywhere. We can't give her everything. It's why she has GGs and pops and grandparents everywhere. She has people who love her, and we're surrounding her with, different people that can supplement her diet, because mom and dad can be everything. We're not like a buffet. We're just, we're just mom and dad. Exactly. We're just limited. We'll try our best for you, but we want to show you that we have community too. We don't live life alone. So that's my approach to parenting.
And that's so great because it takes a village. Even for me as a single parent, I've been single parent for like 20 years more. And raising my children, I had to connect with other people.
Wow.
And, whether they are African American from the Caribbean or people from, even white community, that I connected with, and make it a village. And people contribute their own part in terms of, help you with your child. So it's something very challenging. And like we talked about before, back home, it would have been different because you have connection with the whole community, you have family, you have everybody around you to be able to help. But you are doing a great job because I was seeing happiness in her face all the time.
She makes us happy.
All the time.
She makes us happy.
That's the most important.
I've become one of those parents. I can't stop talking about my child. No, I get it. Before I'm like, why are you always talking about your child? Like, but I get it. Like, I cannot stop.
It's such a beautiful joy. It's a beautiful thing. So now let's go to your specialization and your expertise in health related regarding cancer and your research in rare diseases. So Dr. Ogunsanya, you earned your master's degree and PhD in pharmaceutical science.
Yes, ma'am.
University of Texas in Austin. And most of it in public health. Your research interest is primarily involved understanding health behavior among underserved minority and use a patient-related outcome to capture diseases burden in patients with rare diseases, cancer, and other illness, other diagnoses as well.
Patient-reported outcomes,
So, and I understand that in early part of your research background was in HIV/AIDS in Nigeria.
Yeah.
Would you talk briefly about how this experience prepared you for the work you are doing today?
Very good question. So, right out of pharmacy school, I started working with Chevron. And the environment in Chevron was very different in the sense that they didn't pay for drugs. right? And because it was something that was provided, gratis to the staff and eligible beneficiaries.
Okay.
And they had the best of the best. It was also at Chevron that I learned about working in a diverse team, because during ward rounds, we had doctors, pharmacists, lab scientists, nurses, we all get together in a room, talk about the patient, discuss their case, and then pharmacists will give their feedback. So it was a holistic way of just looking at patient care. And there was no hierarchy, like doctor is number one. The patient was centered. And I'd not seen that as I then being practiced in Nigeria, except in Chevron. But after working there for a while, and I realized that I needed to maybe add more value to myself, because I only had a bachelor's degree then. Then I started working with HIV/AIDS, people living with HIV/AIDS, in Ibadan. And also they had some form of opportunistic infections like tuberculosis and such. So it was there that I really started understanding more about, and if you can even contrast the environment, Chevron had like privileged, rich, elite people. So now working in a place where some people would drive from Ogbomoso or Ilorin to come and pick up medications because it was free. So way back in the early 2000s, President Bush set up PEPFAR, which is the President's Emergency Plan for AIDS relief in Africa. What they did was that we're going to provide the drugs, and the governments of those countries would provide the infrastructure, the human power, and then also salaries. But the drugs, which were super expensive then, because this was still the early phases of drug development for HIV/AIDS, were made free to these countries. So the patients didn't have to pay a dime. We also provided formulas for mothers who couldn't breastfeed, because HIV can be, the virus can be transmitted.
Yeah.
Okay. And there was a spate of married moms with kids coming down with HIV. And we found out that in the early 90s, during the CS craze, some people received blood that was taken with HIV. Because then the way of detecting the virus, the methods they used didn't screen for when the virus was in a latent phase. What does that mean? The virus has a phase where it hides.
Yeah.
And so these tools weren't quite sophisticated to be able to screen it then. So let's say, for example, you come down with a flu or a cold, or your immune system gets shut down in a way, then the virus becomes activated. And all of a sudden, you're coming down with HIV, something you didn't have before. And so imagine you telling your husband that he didn't cheat on you. And then you had HIV. And then the child you had during the whole process, because you received blood when you had your cesarean section, also had HIV. So you had mothers and children coming. And this was a time where it was heavily stigmatized. So having HIV and having stigma, I think, and then coming straight from Chevron, it was almost like, wow, this is different. And I was fresh out of, pharmacy school. I was quite cocky, super bright. I just told myself, whatever I told my patients they had to do, because, I was the authority. I knew what the drugs did to the body. I knew what the body did to the drugs, but I had no idea about patient behavior. Even though these drugs were free, why weren't they using it? And every time they'll come to the hospital for the appointments, usually 3 months, 6 months, depending. Some of them will give them like 6 months if we can trust that they've been taking their drugs. So the more we can see that you've been consistent or adherent, you could get longer drugs, like pickup times. But every time you come, by the time you come to the pharmacy was the last point of call. You'll have gone to draw your blood levels. You'll have seen the doctor, seen the counselor, seen the nutritionist. So by the time you come to the pharmacy, they're frustrated, they're tired, they spend the whole day waiting. So we're at the receiving end of those frustrations, but we also see the whole picture. So you ask a patient, did you take your medications? They'll say yes. But you look at the blood is saying something else. Because in HIV, we look out for two things. The CD4, which is like your white blood cells fighting for you. We want those numbers to be high. Yeah. Because it means your body's fighting to kill the virus off. We want the viral load, which is the load of the virus to be low. So one is working high, one wants to be high, one to be low. Yeah. So if you're not using your drug, guess what? Your white blood cells will be lower and your viral load will be higher. And there are some that, the higher it becomes, the more you're at risk of infections. Yes. So if two people can be standing in the cold, now one person will catch a cold, the HIV person might end up dying because the cold will kill them faster. Yes. Because their immune system is shut down. Sure. So when a patient is telling them, I'm taking my medication, but their blood is saying something else, you're seeing the whole picture. And I start understanding that these drugs have a lot of side effects that will even give them away. I recall a police officer who was on efavirenz, which made him see he had vivid dreams. He couldn't sleep. So he was having insomnia and he was sleeping on his job. Wow. We had one that had Steven Johnson's reaction, which caused a lot of rashes to come out. I know that if you have rashes, you start thinking, this is not HIV. You know how we just toss the word around. Yeah. So, and the drugs were Now things are better. We've combined pills. We've been able to maximize therapeutic outcomes. But then you had like assortment of pills like M&Ms for patients to swallow. I'm a pharmacist, but I hate taking drugs. My husband would tell you I'm the worst patient. I can't even finish the course of antibiotics. But I look my patients in the eye and be telling them they have to finish their medications.
Yes.
So that frustration drove me to grad school because I realized I didn't know about patient behavior. They had taught me about the science, but nobody had taught me about patient behavior. Why would a patient take a drug that was free? Why would the patient listen to a smart pharmacist telling them why they need to take their drugs? Especially when you're showing them the picture of their graph going up. 3 months before, your virus was this level. Now it's gone up. You know something has happened. They're not taking their meds. So that drove me to grad school to really understand that. So my first project in grad school was just looking at patient behavior for HIV adherence. And in 2006, I lost a father figure to cancer. This was when cancer was still coming up in Nigeria. You know, you hear the word, but it was almost like, not our portion in Jesus' name, right? And this was someone who had poured so much into me. I talked about not having a close relationship with my dad growing up, but I had some father figures who were there. My parents lived together, still live together. Just for, it was just the way it was. This was one of the men that, my mom used to work with. And I think he had read one of my poems that I wrote about my mom. And so it was my mom's boss. He was like, oh my goodness, like, I'd like to meet your daughter. And he became like a mentor to me. Helped me open my first bank account. I remember then it was a Standard Chartered. It was 10,000 naira. He got me my first camera. Like being able to just, see, like have a different male figure to like, be able to talk to about things. So it was a very positive role model. And he used to encourage me to pursue my hobbies and my creativity. And then he had cancer. And my mom told me about it. It broke my heart because he was a genuinely kind man. We knew his family as well. And then whenever we had gone to see him, my mom warned me that he was going to be looking different. But I wasn't, no matter how she prepared me, it wasn't enough to, get me ready for what I was going to see. I actually passed right by him. I didn't recognize him. And I went to his room. I'm like, he's not there, Mom. He's not there. Where is he? He was like, you just passed by him. What? You mean that old man? He had gotten old all of a sudden. He had shrunken to like a third of his body size. And I broke down crying for 2 reasons. This is what cancer does to people.
Yes.
And why did I recognize him? I felt so bad that I did not recognize him. Now, he had all the money. He was very wealthy. He had gone for one course of chemo. They stick it out. Then he did radiation. But he ended up dying from it. And so if you ever pick up my thesis, it's dedicated to him because I don't want people to go through that. It stayed with me. I was 18 when that happened.
Yes.
And it stayed with me seeing what I saw. And so in my research, what I'm trying to do is to start a conversation on early detection. We're in a world now where there's so much sophistication around detecting cancers, but we have to present ourselves to the authorities. By authorities, I mean going to the doctor's office once a year, at least once a year, for peace of mind. It's not very easy for me. Like I have hospital trauma. As someone who has been through IVF countless of times, I can't tell you how many times I've been faced with incompetent and culturally insensitive doctors in the US when it comes to fertility issues. And so going to my gynecologist's office is like a triggering thing for me, but I still put myself through it because why? My health is number one. So every year I draw my blood, I do my breast examination, I check my cervix. And so I encourage my friends around, they know me, have you done your health in your checkup? Do your health checkup? Because the earlier we detect most cancers, the better our odds of surviving. So that's what I bring to the table. And of course, we have some unique peculiarities as being Blacks. We are predisposed to some other things that other races might not be. Take, for example, prostate cancer is quite pervasive in the Black community. And usually Black have, worse forms of it at the stage and grade of presentation. There's also been a gene which they've been able to sequester, especially in Black men. It's called the 8q24 gene. And it's been linked to causing aggressive forms of both prostate and colon cancers. And then the issue of slavery. So in Brazil, for example, across those transatlantic slave routes, we're seeing, high cases of cancers in the community, especially in the Black community. So something about being Black, because a Black man in the Caribbean, in the West Indies, in the UK, in Africa, was suffering from this ailment. So it has to be more than just, our environment. It has to be something about the race itself. Maybe some allostatic, stress loads. I don't know, but there's just something about it. So my key thing is just working with this community and finding ways where we can use the models, use Black men to train other Black men of taking their health seriously and being more proactive participants in their own healthcare. So, yeah.
That is so, you cover so many areas, even without questioning itself for that. Because from your background, from what you experience in Nigeria, I believe that's what pushed you to focus your research on health behavior for underserved community, which include minorities and many other underserved community, maybe white or any other group that they are underserved. Because when we're talking about minorities, even with the whites who are also
white matter, yes.
Because capitalistic system does not care about race.
It doesn't.
Which is what I always tell people. It depends on how you could advocate for your own self, and you could go against the capitalistic system, okay, and say, you know what, I'm going to demand for the best for myself, which is what we minority needs to get together.
Yes.
So understand. So how has your research work focusing on underserved and minority community in America taught you about racial inequality and medical injustice among the vulnerable population of this country?
That's a very loaded question. I think there's a lot of work to be done. And my fear is that a lot of things just get shoved under is what it is. It's just what it is. There's not much you can do. The biggest thing I've seen so far, especially in the population I work, so I work specifically now I have 2 streams of research which talk about lupus and prostate cancer. And I work with Black men who have survived prostate cancer. I see how, for example, your zip code determines the kind of care you get. So in cancer diagnosis and even treatment and eventual survivorship, one of the biggest concepts to look at is decision-making, right? Your decision-making regarding what kind of therapy to choose, because there's so many ways to treat cancer. And if you're not armed with the balanced information about the pros and cons or the options you have, then you're just limited to what you have. So take, for example, if I'm living in a zip code where there's only one regional hospital there. Now, if I traveled maybe 2 cities down, the road, I can get better care. But who's going to take care of my kids? If I'm off work, some of us are not able to leave, pack up and go to the Mayo Clinic or MD Anderson to go and get care. You're limited with what you have. And some places in the US here, they don't even have primary healthcare centers enough to cover for the population. How much more for cancer? And so if you end up having a surgeon in your zip code, what does the surgeon want to do? They want to cut. What if surgery is not the best option for you? What if it's radiotherapy? What if it's chemotherapy? What if it's active surveillance? What if it's a combination of any of those things, right? And so we're seeing things with what you call decisional regrets. Men regretting the treatment they had. Now they survive cancer. Trust me, most men will survive cancer. They will survive prostate cancer, that is. But then what does survival mean? If you're not able to be a man anymore, if you're not able to function, if you have pain in your rectum, if your bowels is leaking, if you cannot hold your urine, if you're not able to have sex, if you're gaining weight because you had hormonal therapy. I had a man tell me that he started growing boobs, he started having PMS, because he was on hormone. And you know how masculinity is such a very important concept to Black men as a whole. So these are some of the things I'm saying as far as decision making and men not being given the right information. And maybe it's not even the right, it's not like the doctors are trying to be dubious. I feel like there's a lot of training that has to come. It's very cultural sensitive trainings when men have to work with diverse populations. And I'm speaking for Black men because that's the population of Asia, but I know there's diversity in every culture. So please permit me to speak about Black men because that's the one I'm familiar with. I'm not saying diversity only ends with Black people, no, but it's the one I'm familiar with. So in our lab, we delineate what Blackness is. We just don't look at Black men for what Black men is. Look at Black men from different ethnic groups. So as you and I, we are African, immigrants here in the US. We're Africans first, right? So I look at Black men who are born from Caribbean countries. I look at native-born Black men. I look at African-born Black men because there's some additional factors like their immigration patterns, their cultural norms, which would take, a lot of precedence when it comes to deciding what kind of therapy they want to take. So in Nigeria, for example, where the healthcare is paternalistic, in the sense that when the doctor tells you what to do, you just say yes, right? Although things are changing now with this generation being more vocal. But imagine this older generation where it's almost unseen of to question your doctor. You just it. So if an African man goes to a doctor's office and it ends up being a white doctor who's not very culturally aware, at the very least aware, and you're telling your patient, this is what I need you to do, and all that, and they're telling you, okay. But that okay doesn't necessarily mean that they know what they're saying. I'm not saying that they're dumb people or no. They just maybe to them it's like, I'm not going to disturb this doctor's time. He's probably busy.
Or language barrier.
Or even in that state, when you've been told you have cancer, like almost like world just ends.
Yes.
So Ari had the flu the other day, and the flu was so bad she couldn't get out of bed. She kept complaining about her bones aching. I almost lost it. None of my pharmacy degree was even helpful. I was just a lost mom. I started panicking, called my husband. She couldn't get out of bed. It turned out she had influenza A. But in that moment, none of my medical degree or whatever I knew was helpful.
Yeah.
I was in a compromised state.
Yeah.
It's just as well I didn't study medicine because I don't know how I've been able to do it. But my husband was able to calm me down, remind me that maybe it's just the flu. Let's go get her tested. And it ended up being the flu. Now, and this is me having a physician in-house. Not everybody has a physician in their house. It's that if you've been told you have cancer, which we know people associate with a death sentence.
Yes.
So I feel like it's very important for us to incorporate ethnic differences in our research that addresses health disparities. Because for us to categorize our data based on ethnicity and their nativity to the US, we want to identify potential knowledge gaps so that we can develop effective programs and policies to address disparities. Now, even as an African, like I have my culture, the way I do things, even though we share similar genetic characteristics with a man born in the Caribbean, for example, there could be other factors such as our environment, lived experiences, our cultural beliefs, our norms, our values that make a lot of differences in our mobility, right? So one of the key things we found in our research is when it even comes to relationship with healthcare providers. Now, that example I gave about Nigeria being a healthcare system and the generation of men who are now having cancers, these are the older generation, right? By the time they come here, the trust they have for their doctors, they bring it to the system here. So they're able to establish that contact of care within the hospital. But then a Black man born in the US is less likely to have a regular family physician or a physician they see on a regular basis. For so many reasons, there's distrust of the system for good reasons. With the Tuskegee experiment and things that have been done in the Black community. But a Nigerian man is different because he's not taking his health for play. He's going to go see it. But sometimes the over-trusting of your healthcare provider without you understanding that they also expect you to bring your own second opinion and go advocate for yourself. So you can see just how both sides, there are the pros and the cons of it. So
And it's so true because even one thing that I see within people of color, our community, there's no lack of support group among ourselves when it comes to whether you're talking about diagnosis with cancer or some other health issue. When you go, for example, among the white community, they have different support group for different issue. So they share information. When they try drugs out there, it's available to them because they want to take it and said, maybe I could take this medication. I could apply for part of the trial group to be able to take this medication. Maybe it could work for me instead of me going for chemotherapy. So all those information is not actually available. And sometimes I blame us. And we are not connected with seeking information because nobody's coming to your community to pour things down for you.
That's true.
And you have to be the one to search for those information, or else you'll be part of the statistics. So it's part of what we need to push more in our community, and actually also educating ourselves in accepting whatever we're going through, to have a way of not being ashamed, to not be ashamed of what it is that we're going through, and to be able to feel comfortable talking about it openly without being shamed or put down and said that, this is what that person is going to, or they're going to laugh at me. Don't let me even think about it. So it's a lot of, like you said, that cultural aspect of things has to come. And also, I was talking to someone, recently in one of my podcasts, and she gave advice that you always seek Black doctors. And I said,
it's not sustainable.
It's unsustainable because
I live in Oklahoma. How many Black doctors
are there? There's not enough Black doctors.
Everywhere.
And doctors deal with different specialty. They have different specialty in different medical fields. But we have to now start talking about culturally sensitive
competence. That's I'll prioritize that over seeking that.
Because
the Black doctors sometimes are not culturally competent.
Thank you.
Yeah.
So it does not mean, because I've met so many people that you share the same race and they can't connect with you because, even sometimes they might even be arrogant towards you without actually wanting to spend time to get to know what you actually need. And you might find another doctor who is actually Caucasian, who actually connects with you, who may come from an immigrant background, or maybe their parents are from India, from China, that they also came from immigrant background, and they understand and they could connect with that. So it's a lot that we have to, talk about this openly. And this is so great information that you're giving here.
Thank you.
Your concentration in research is in US is mostly in what area of cancer?
So prostate cancer, which is currently the most frequently diagnosed cancer among Black men. Mm-hmm. And it's about 41,000 incidents, that's new cases in the US for this year, and then 6,000 deaths among Black men in the US. Now, although the incidence rate, which is like new cases, is 60% higher among Black men than non-Hispanic white men, and it's also more likely to be diagnosed at an advanced stage. Now, what are some factors that are attributed to these racial disparities in survival outcomes in Black men? Genetic susceptibility. So I talked about the 8q24. Then also there's a theory that Black men secrete a lot more testosterone, which is a further for prostate cancer. So that might also cause accelerated and even more aggressive forms. Reduced access to healthcare, family history, socioeconomic factors, and late detections, are factors that are related to it. Now, when it comes to prostate cancer, there are three major risk factors. The older you get, in fact, there's a joke among the prostate cancer community that Methuselah from the Bible, if they dug up his body now, he probably has prostate cancer. The older you get, the more your chances are. Family history, right? So if your father or first degree relative has had it, you have a chance of having that. And then lastly is being Black. So those two things now, they're non-modifiable. I can't change my race. Last time I checked, I can't change my family history. No. And I cannot stop myself from growing, except if you should just die. Now, there's some cancers that have poor survival outcomes. Take, for example, pancreatic cancer. Some of them have like 9%, it's like almost like a death sentence. But for prostate cancer, it's about 97%, which is not bad. It's a good odd to have, but meaning that men are living longer. But even though they're living longer, there's a lot of things they have to cope with. And these are really heavy, painful things, man. I've worked with survivors for the past 4 years, and I've been doing prostate cancer research for the past 10 years. There are physical issues, there are psychological issues, there are psychosocial issues, there are mental issues that really persist long after they've recovered from the acute phase of treatment. So that's my goal, because even though the numbers of cancer diagnosis, prostate cancer is reducing, but if we were to split that number and look at the within group differences, Black men are not doing well. They're not doing well.
That's the sad part.
So
and we have to promote all this health information or health issue. When we talk about Black men, we also need to differentiate, because you have so many African men here who have health insurance, who have so many opportunities to
they just don't
do the checkup regularly, do what you're supposed to do. And they're afraid, even some are afraid to go to the doctor and say, I don't want them to discover anything in my
For good reasons too.
I don't want anybody to discover anything, because if they discover something, then I will start panicking and upset because I don't know what they will find. But, you have the opportunity to go in this country, you should. And, I want to move the conversation. You've done so many studies in America on American society that even with all that, you never abandon Africa when it comes to concentrating some of your studies of cancer in Africa. I read one of your co-authored commentary paper you wrote with Matthew Dixon on state of cancer in Nigeria.
That was my student.
I want to further discuss with you on that. For reference point, I also read other journal published by Frontier.
You're amazing.
In oncology, tied to 10 years mortality pattern among cancer patients in Lagos State University Hospital in Ikeja. As both journals cited, there is an estimated 72,000 deaths in Nigeria yearly, and another estimation of 102,000 new cases annually. What would you say are the root cause of increased rates of cancer in Nigeria?
So first of all, kudos to you, Ma, because I could never, because when I write the paper, it's like, out of moving on to the next thing. But thank you for taking time to dig through the research and even synthesizing it and coming up with questions. Really, really appreciate you, Ma. So first, I want to say with 90% probability that those numbers you just cited are underreported.
Yes, I felt so.
I mean, so no, in the US alone, because Nigeria's population is what, 211 million? US like 300 million. No, it's underreported. People will die. They were like, oh, he had a brief illness. How brief was that cancer? Uncle had cancer for a while. Now, I think there are many factors for that. Number one, we lack a comprehensive national cancer-related data system.
Yes.
For example, cancer registries, they are not well developed in Nigeria, and data collection is often inaccurate or even incomplete. Now, so as a result, also, additionally, we have limited numbers of trained pathologists in the country to accurately not only diagnose prostate cancer or cancer, or even also report those cases of cancer. So as a result, many cases of cancers go undiagnosed. And deaths due to cancer may be inaccurately attributed to other causes.
Yes.
Then also, we also have cultural and social factors that surround illness and death in Nigeria. See what? Oh, my dear, it's not my portion. No. Don't tell anybody. Don't tell anybody. Yes. Remember one of those 3 factors I told you about, risk factors? Family history is one. But you don't know that I'll say 80% of the men in my cohort never knew their family history. As a matter of fact, a man in my study learned about his family. Like when he had cancer, he had a brother that had cancer, but he never knew. His brother never told him about it.
Yes.
It was a sister who lived somewhere else in the world that said, oh, your brother had the same thing. He called the brother and the brother flat out denied it.
What?
The brother's daughter, which was his niece, called him and said, yeah, dad had it. But the brother today never owned up to it. For whatever reason he has, I don't think he was doing it deliberately. These are some of the issues we are running through, because when we withhold this kind of information from our loved ones, we're putting them at risk. Yes. So men will go to their grave not telling their wives about their cancer status. Your progenies, your sons have a high risk. As a matter of fact, your daughters, because now we're seeing linkages between men with prostate cancer and their daughters with breast cancer. So it's not even those your sons anymore. If you say, oh, I don't have sons, I only have daughters, they need to know. They need to know. So many people in Nigeria die at home, and die in such a way that their family don't even know what they died of. So those are some of the issues, and also the weak infrastructure system. In that article that we wrote, our country is not even equipped to handle communicable diseases like malaria. See what we did with HIV. Yes. We've regressed to the mean. Countries like Botswana, they've done a better job at, now we're seeing increases in HIV rates in Nigeria. The gains we made many years ago is been reversed now because the government hasn't matched up to their making sure that, these infrastructures are well in place. Now, we're living longer. Our life expectancy is getting better. What does that mean? Non-communicable diseases like cancers are going to be, yes. In the past year alone, I've had 3 friends. I don't know if you remember that we raised money for one of them. Oh, she's just cancer-free now, but she's 40, Kosi. Yeah, she's lost one of her breasts. Yeah, she's lost her breast, one of her breasts. She sent me her PET scan yesterday. Thank God she's cancer-free now. Thank God for that. But at 40,
can you imagine?
Diagnosed with cancer. I had another friend's sister. She was 30-something. She had to have a mastectomy too. And we're not seeing younger people coming up with cancer. We're also seeing them in aggressive forms. Stages 3, stages 4. And our system is not even equipped to handle what is coming ahead of it. So, and then we have politicians who go abroad for treatment, leaving the masses to suffer. So what does that tell you? So there's so many issues we have. And then I think last thing to also add before I go into your question will be the lack of that registries, because in the US now, there are several registries that collect and organize our data. Our system is broken. We even hold on to this data. From what I've heard, I might be wrong in this, they use them for they're not openly available to see what is there. So the paper by Dr. Fatire was only considered in LASU. And that's, region. It's not even regional. Talk more. So take, for example, in the US, we have several registries. The popular ones I'm going to mention, there's the NPCR, which is the National Program of Cancer Registries. And this is managed by the Centers for Disease Control and Prevention. And it collects and analyzes cancer data, and it's funded to allow all these 46 states and territorial cancer to kind of put all of their data in-house, in a centralized position. As a researcher, I can get access to the database. If I want to know what is the cancer incidence in rural Appalachian, I can get those data.
Yeah.
I can get access to it. It's open. I might pay a little bit of money, but it's open for me to be able to get access to it.
Yeah.
There's CS, which is a commonly used one, is the Surveillance, Epidemiology, and End Results. That also is a national cancer surveillance program, and it collects information on cancer incidence, on mortality and survival from regions in the US.
Yeah.
And every region they have to pull in their data so that way there's a centralized repository. We don't have that in Nigeria.
Mm-hmm.
So people are sitting on this. Mm-hmm. And the importance of registry is that it plays a vital role in monitoring cancer trends.
Yes.
Informing research and treatment, and also developing targeted interventions to address cancer disparities. Yes. My fear right now is that we're seeing younger people in Nigeria coming up with cancer. My friend Tolu, I don't know if you need to talk to Tolu. I have to introduce you to Tolu. Tolu is from Cancer Aware. Tolu does a fantastic job of matching people with resources when it comes to cancer. But she's just one person. And the system is overburdened and underprepared because the worst is yet to come. And I hate to sound very negative about it, but I don't think our government is ready for the thing that is coming ahead, because we're seeing more younger people now coming up with cancer. And to treat it, they have to end up doing donation funds.
Yeah.
Because then my friend Kosi, she works for an organization, a health-based organization. She had health insurance, but they told her they don't cover cancer treatment. It's only malaria.
In Nigeria,
ma. And I don't.
So what's the purpose of?
It's more of her employer. Exactly. We had to raise money for her. She needed about $40,000 to be able to do PET scan, to do BRCA gene testing, to be able to be on medications.
But what set of politicians or people in power are we promoting in that country? I'm going to say it clearly, we're promoting thugs. And those who don't, yes, we're promoting a bunch of thugs. And those who have no idea or clue or have any interest about the population that they're supposed to be serving.
Spot on, ma.
Rather, supporting their own pocket and bringing the money abroad, because right here in New York, I've heard many of the politicians who
they're there. Yeah,
there. They have houses on Central Park where the apartment is going for billions of dollars. They have it maintaining it. What sense does that make you? What kind of human being is that, where majority of your population are suffering from the money that's supposed to go for the care of the population, you bringing it abroad to America, to different part of Europe, because, and like I said before, it's so frustrating. Is what we as a society, we need to engage in this kind of conversation to educate masses about the impact of what many of these politicians are doing, so that we start talking openly about and stop praising them, stop empowering them.
Yeah. So I don't know if you heard about the Abuja Declaration that was done in 2001.
No.
It was a commitment by African governments to allocate at least 15% of the annual budget to healthcare sector. This has been 2001. If my math is right, that's 22 years ago.
Mm-hmm.
Do you know how much the allocation for our health is recently in Nigeria?
Yeah, what?
It's 3.6%.
What?
Mm-hmm. It's significantly lower because the average spending of per GPT by high-income countries is about 9.8%. So Nigeria's healthcare spending is even low. So that has resulted in inadequate resources, infrastructure, and has also led challenges in delivering, quality healthcare services, especially in low-income rural areas.
Yeah,
we're not spending enough. Our budget is, it's not up to par.
How do you think religion has influence on how we see health issue?
Without religion, I think most of us would have been dead. I see that as a double-edged sword. It's a coping mechanism, because take away religion, the religious leaders do a lot when it comes to mental health services. It's like coping through the hardships of Nigeria. But I also think that the bad ones do enough bad that the good ones are not being acknowledged. Because religiosity and spirituality is a big concept when it comes to cancer. Let's talk about cancer, for example. And the ability to just take your way, like outsource your issues to a higher power. We can talk about the merits of that. But the problem with religion, when it becomes a problem, is when it's taking the place of things that you should have addressed in the first place, right? And I feel like this is where religious leaders should be trained. And even in attending Dr. Pure's presentation yesterday, we talked about FGM and all that. There's nothing stopping you from going to see your doctor and do your healthcare checkup just because you're religious.
Mm-hmm.
And I think training them on just the importance of screening. Yeah, I volunteer with health fairs. They are held in churches.
Yeah.
Pastors come out and we do walks. We do cancer walk. They
Mm-hmm.
talk to their church members on screening. We take our messages on the road to the communities. They're done here. We can replicate that in the mosques and churches in Nigeria. We can keep serving our Jesus and Muhammad, but at the same time, while we're on earth, our bodies are corporal. They're human bodies. They're prone to decay. We should talk about the importance of keeping our health. So the bad side of religion is when it's used in that way to hold people captive. But I've also see it do some good. When people turn towards a higher power when they have cancer, it's one of the most beautiful meaning. It gives them more meaning to their journey. I'm able to speak to both sides of it, the good side of it and the bad side of it. But I think Nigeria, it's done sometimes to the extreme of it, which is what we're seeing. Yeah.
In terms of some people will say, oh, Bolon Shefeni. Yeah. Just accept it. That's how
fatalism. That's what it's called, cancer fatalism. We just, it's God's will. Maybe that's what God's will.
That's what it's meant to be, and also that actually affects us, not actually pushing and said, we deserve better than this. We deserve to live longer. I deserve to see my children grow up. I deserve to see my grandchildren grow up. So when I was growing up in Nigeria in the 60s, when I was born, and through the early 80s, when I left Nigeria, I really knew someone who was diagnosed with cancer or died of cancer. Was it because of lack of awareness at the time that people were actually dying of cancer? Or was it due to recent environmental changes? Or maybe exposure to toxic agents that was foreign to us? Changes in our diet, or maybe consuming alcohol or smoking, or environmental exposure. Why is it the rate so high now?
Well, I think one is we're living longer, right?
Mm-hmm.
Definitely. So when a population is living longer, you're more likely to see those chronic forms of diseases, right?
Mm-hmm.
Environmental factors, which you've alluded to. So exposure to environmental toxins such as air pollution, pesticides. So 2 years ago, I was in Nigeria. There's this talk about Dangote refineries coming to somewhere around a main estate. And I heard that people were rushing to go and buy land there to live there. I'm like, duh. People don't know about those downstream effects. There should be proper zoning in place. Where a factory like that, a refinery, you shouldn't have any house within that zip code, because their slurry and all of the things they're taking out, those are toxins that are going to be released in the water. Geography major. It doesn't take a rock science, like a degree in science, to be able to understand the impact of that. Even industrial emissions, these have been linked to various types of cancers. Poor sanitation and hygiene in some communities may also cause exposure to harmful agents. Lifestyle factors. Our food is not quite as refined. They've become more refined.
Yeah.
When I moved in the US, I used to say that organic food was cheaper back home. KFC was more expensive.
Yes.
But now I want to bam bam, want to roll with the big boys, want to, have KFC and, all those food that, it goes against our biome and, genetic biome. So that's also causing some issues. Alcohol as well. Not even having access to fresh foods and vegetables. When I was in Lagos 3 years ago, I drove from Omole to ShopRite on the island to go and buy green salads. And man, it was a poultry sum of our baby. It was like 10,000 naira for kikini buy. Imagine the drive all the way because I wanted to eat greens. The marketing, they didn't have, they had greens for soup, but not salads. I wanted salad. And Nigerian salad is heavy in carbs. I wanted the green salad, no Nigerian salad. It was heavy. I wanted green salad. I wanted green salad. So imagine driving all the way to go and get that. And of course, genetics, right? Some cancers, such as breast and prostate cancer, may occur due to genetic modification, mutations in younger people. There are limited access to diagnosis and screening. Now, early, we cannot, we save money to buy hair, to buy shoes, to travel.
Ashwebi.
Put money down for your health. Like, it's not, I don't look forward to my health, my yearly checkup. I don't look forward to it. There's no time I will not live there in tears. Not because it's sad. It's just overwhelming for me. I just cry in front of my doctor. I'm in good health, but it's just very overwhelming for me. Again, because I've gone through so much in the hands of healthcare providers. They haven't always been nice to me, but I still go because I prioritize myself first. So the earlier we screen for this, the better our outcomes will be. And then finally, again, we're living longer, which I've talked about. Infectious diseases too. So Nigeria has a high burden of infections diseases such as hepatitis B and C.
Mm-hmm.
And these infections can also, are also risk factors for some types of cancers, like liver cancer, like cervical cancer, even Kaposi sarcoma. So again, screen yourself. 10,000 or 50,000 naira a year. Put it aside and just go do your blood work.
Yeah.
So what are some of the things you want to look at in your health? Just your metabolic panel, your blood counts.
Mm-hmm.
Check your vitamin Ds. Africans, some of us have low vitamin Ds. That's why you're prone to depression and aggressive behavior sometimes, because if you're low in vitamin, it can have issues with your mental health. So check your vitamin. My vitamin D levels was very low in the US because we don't come out in the sun a lot.
Yeah.
But also think that because you're black, Shabi is melanin popping. No, check your vitamin D levels, your calcium, your A1Cs, your blood pressure. Just please check your health once a year.
Yeah, and exercise.
Yes, forgot about that. Working on physical activity, it does body good. Yes,
because when I was back in Nigeria, when people drink, they eat, they don't add sugar. Especially people who drink pap, a corn meal that they drink. They eat or drink, they don't add sugar. They actually add sour water.
To kind of bring it out.
Because there's so many people in those generations that they never even tasted sugar.
And the sugar was maybe natural self. It wasn't like the refined one we have.
Yeah, the refined one. And then in the olden days, when I was growing up, people would walk from Lagos Island all the way. They could walk to Surulere.
My grandfather was like that. From Ikorodu to Surulere.
Surulere. And they are very active, even though there was nothing like going to the gym.
And he had a farm. My grandfather had a farm. Yeah.
They do a lot of hard work and everything, that they sweat a lot. But this new generation, when we're looking at all those lifestyles being, uncivilized, and we look down at those who were, living at that time. So it's not something that you actually promote.
Even here, like, you drive in your car, you're entering garage to garage, you're sitting down.
Yeah, that's what it is. So what would you say are the main cancer diagnoses in Nigeria for men, women, and children? Which is similar to other African countries as well.
I think it's similar, yeah. And with Nigeria, we are the most populous Black nation, right? So for men, it's prostate cancer, For men, it's prostate cancer, sadly enough. And for women, it's breast cancer. And the thing is just, again, we're seeing younger people in their 30s, in their 40s. This hasn't been before. And not even them just having it, but they're having aggressive forms of it. Unprecedented rates, man. So those are things that I think the burden is going to put on the healthcare system. And the government cannot hide from this for long, right? So again, we have men, prostate cancer. Now, childhood cancer is rare in Nigeria, but the most ones you'll find will be leukemia, retinoblastoma, which is a cancer of the eye. You can also have Wilms tumor, which is a type of kidney cancer, breast cancer, and I also forgot to mention the cervical cancer. Now, other cancers, common cancers in Nigerian women are ovarian cancer and colorectal cancer. Again, it's essential to note that cancers in Nigeria, cancer rates may be underreported. Our cancer data reporting systems are inadequate. We also don't have access to screening and on-time diagnostic services, especially outside major cities. If you don't live in Lagos, Abuja, or those big cities, even their primary healthcare centers, they're just enough to handle the load for malaria and childbearing. How much more cancer? Cancer is heavy on infrastructure, man.
Yeah.
It eats into your resources. So, yeah.
That's really something. So I want to bring you, we're almost done anyway. Government and vaccination, because when I was growing up, there were vaccination in Nigeria. Within a certain age, they vaccinate all the children against certain diseases and all that. So understanding that cancer is, like you said before, is like a death sentence in Nigeria. When you have it, there's no way out. And also in many parts of Africa. And when I was reading through all this research, and I understand that Ethiopia has been the first country in Africa that has high cancer rate. High cancer rate
in Africa?
In Africa. In sub-Saharan Africa.
Oh, sub-Saharan Africa.
Egypt.
Egypt. Egypt. Yeah, Egypt. Ethiopia is not. Yeah, it's Egypt.
Egypt, followed by Nigeria.
Yeah.
And then South Africa is number 3 when it comes to it. So
I still think it's Nigeria though, but for me, I'll just keep that because again, I think it still goes back to underreporting. But
yeah, which you are right, underreported, and they have to do a better job in that. Yeah. So when you look at giving vaccination, especially in this country, I remember when my daughter was young, they were giving vaccination against cervical cancer.
Yeah.
And I make sure that I read about it. This is part of what the government could have put their money into and vaccinate young girls against this kind of cancer. And I know they have do they even have health departments that actually advise the government on what to do?
I think they do. Yeah. So there's Gavi, which is like the Vaccine Alliance, and they help to vaccinate, almost half of that. They've been, this is an international organization that has also been quite involved in Nigeria in helping with, for example, with the cervical vaccine optics. But the problem has been with cultural issues, especially in the northern parts of the country.
Yeah.
Cervical cancer and vaccines, cervical screening, for example, the vaccines, for example, have been linked to, so because of the age, they link it to promiscuity in girls.
So they say that again, I don't understand.
That why you screening them against them, they'll be loose, they'll start having sex early. Why are you screening? Because the way it is that if you want to start giving the vaccines at a younger age,
yes,
and it also coincides with when a girl is coming of age. So for a lot of ultra-conservative environment, they equate that to that you're almost like you're giving them condom to go and be loose and have sex and all that.
All that miseducation.
Because it's supposed to prevent against, because cervical cancer can be transmitted through sex, right?
Yeah.
So why are you giving it to a child that is not supposed to be having sex in the first place?
There's a lot of work to be done in that country. So I just want to ask you, I'm almost done. If you are in the position to advise African leaders in different countries, what kind of advice would you give them when it comes to addressing the issue of cancer or, diseases that is killing our population in high number?
I think, first of all, losing the purse strings, the 4% we're spending is too low on healthcare. And you all know that already.
Yeah.
It's because that's why you are leaving the country to go and get healthcare abroad. We need to invest more resources in cancer control by increasing funding for cancer research. We have passionate. So I was a NCI fellow, the NIH is the National Institute of Health, is the biggest funder in the world when it comes to research. One of the institutes there is National Cancer Institute. I was a fellow in 2019, and I met other fellows from all over the world. The African cohorts were very spectacular. They knew us. We left the mark. We're very passionate. It's where I met Tolu, who was an advocate, and she runs Cancer Aware. And we realized that we need to work on the registry. We began working on that, but then the powers that be shut that down real quick. So that was one thing I wanted to tackle. Let us have these registries communicate with themselves. Apparently, some individuals are using them for personal gains because they can use that to get more funding.
Yeah.
Because it's a good way to get more funding, but it's funding that is kept for themselves. So at the end of the day, we're the ones kind of doing ourselves. So definitely, one is increasing funding for cancer control. Then developing comprehensive national cancer control plans. Now, this should be developed and implemented in such a way that it's not just looking at treatments, primary prevention, early detection. It's an all hands on deck approach. Not just, the expert, the community has to be involved in it. The religious leaders, the traditional birth attendants, anyone that is a community leader, they get them to buy into it, because I'm sure at the back of everybody's mind, we don't want people in our community dying. It doesn't look good on us, right? And then strengthen the healthcare system. African leaders should strengthen the systems by increasing access to quality cancer care.
Yes.
Again, this should be equipping them with modern equipment. The hospitals training more oncology professionals and pathologists, and even ancillary service providers like mental health providers. Like, my goodness, at the point of diagnosis, people should have access to mental health, not just for themselves, but also for their families. Cancer is a disease that eats everything up. Even genetic counseling. Say you have a child who has been diagnosed with cancer at a young age, and if their treatment is going to, affect them from having kids in the future, they need to be told how to prevent, like almost like uncle prevention, of uncle fertility, preserving their fertility options, right? Then addressing these cultural myths and beliefs. We need to have institutions, like within the government, acknowledging that we have cultural diversity. I love our culture. I think it's very rich. The problem becomes when our culture starts, limiting our thinking.
Yes.
So addressing all those misconceptions or myths around cancer that might result in delayed cancer diagnosis, like, oh, go and use these herbs, or go and drink that kidney, or apply that to you. A wound that is not healing, you're putting a bone on it. Make it make sense. So they should collaborate not just with the expert, but also with the community leaders or people that will be very effective in addressing this myth. And then last but not the least, I think we've done this too much. I think that's the only thing we've only focused on. We rely so much on international aids, and so our detriment, and even though one of the points would be to keep supporting these collaborations, but I think it should be inverse. We should start opening ourselves up in the sense that we bring our own talents. We maintain control. We're not using control because they're giving us money. We maintain control of our infrastructure, but we're seeing how we can make things done efficiently. But the people at the helms of those affairs should be our own people, not outsourcing them to people that have given us money and will look the other way.
Who are comfortable in their decision making.
Yes. So maybe we can collaborate with them so we can get access to high quality cancer services or cost, effective medications. We've done that with HIV, but unfortunately, that's not a very good example. So I think with these recommendations, we can improve cancer control efforts. Again, it's coming. We're living longer. It's coming. And our younger population, we have the youngest population in the world. So it's just a matter of time. And I hate to sound like a negative person, but cancers are going to be the biggest burden Nigeria and other countries like Nigeria are going to be facing in the nearest future.
Wow, thank you so much for that. So the final question, you and the others in the research field continue to bring awareness to this topic through your research and public awareness. How can Africans in the diaspora contribute to help improving the state of cancer in Africa?
I think what you can do, again, this is what I did. So I'm not going to be able to say this is what everybody should do. What has worked for me? Because by the time I realized that I couldn't go back home, by going back home, not like I'm actually going back to Nigeria in a couple of weeks. By go back home, I mean like be home permanently. Yeah. I found a way to bridge my research in such a way that I'm doing something back home. So one is, find a part of your research that can address those issues back home. So I talked about how in our lab, we don't look at Blackness as a monolithic concept. We look at where they came from, their migration patterns, looking at their cultures and their norms, and seeing how we can help inform practices here so that healthcare providers are aware of the cultural diversity that is abundant in this population. So that's one. I'm also part of a consortium. So shout out to CAPTC, which is the Prostate Cancer Transatlantic Consortium. We have professionals, healthcare professionals, researcher scientists, advocates, survivors from all over, Black nations and all over the world. We have a group where we have access to funds, to grants, to databases, to research questions, to experts, to address these issues, so that people that are already working passionately about addressing this issue. As a matter of fact, the reason I'm going to Nigeria in a few weeks is to give a talk at the Cancer Genomic Conference that's going to be held in Lagos to talk about just African ancestry and the issues with cancer survivorship. So being plugged in those communities of practice can also help in addressing issues in Africa, and just using your platform like this to talk about the issues. I think the charity will begin at home, right? So my family members know me. You have to go check your health. You can't even get any conversation out of me unless you talk about your health. So how passionate we are about the communities. Our communities are our people, right? Yes. And then so strong advocacy, not just for people outside, but also within, to use our voice to raise awareness about cancer, share our knowledge, right? Partnership. And don't come off like, oh, because I'm a brother, I know better than you. No, you don't. You don't. You're not different than them. You're not even better than them, So collaborating, knowledge sharing, it's like bring your knowledge, I bring my knowledge. And together, knowledge grows, right? Nobody's the custodian of knowledge in the world.
Yes.
And if you can donate, I have friends who donate medical equipment. But the thing is that I feel like with donation mentality also goes back to that whole thing of leaning on other people to always come and save you. But I bridge mine through research. I also use my podcast as a platform to talk about that. I brought survivors to my podcast to talk about the issues that are prevalent in the community and also how they went through their own journey and sharing their story around diagnoses, what the hurdles they had, and how life is like there. And then definitely research too, supporting those research initiatives in Africa to help develop new technologies and therapies. But we need to work together. We need to work together. We have the resources, they have the capacity, and they're coming together makes for. Yeah, so I think that participations of Africans in the diaspora can be a significant asset in the fight against cancer in Africa. And that can also make a real difference in improving cancer control and care on the continent.
Yes, thank you so much. I've taken all your time, Dr. Motolani Ogunsanya. Thank you so much. Thank you. I really want to thank you for coming today. So Pansa Pansa continue to normalize conversation about the importance of community engagement about African immigrant experiences in America and abroad. As I always said, as we continue to publicly discuss issue within our community, we are shredding away stigma associated with uncomfortable dialogue. Thank you so much, Dr. Tolani Ogunsanya, for coming to Pansa Pansa to share your wealth of knowledge about the dilemma facing African countries in regard to cancer rate, diagnosis, and lack of adequate treatment. Thank you for sharing your wisdom with our community in the diaspora. And I believe those who will listen to this podcast will really appreciate the vital information that you shared today. Thank you so much.
Thank you. I really appreciate all of your questions. I mean, I don't think I've ever done a podcast episode like this before. Like, thank you. And I know when I get very passionate, I tend to talk so fast. And so just in case for those that are listening, maybe I misquoted a number or something, please charge it to my head and not my heart, okay?
So how can a listener follow you, your podcast, or listen to you, or try to find you if they have to?
Okay, sure. I have two personal. So one is my professional. If you just type in Motolani Ogunsanya on your Google, you'll see a lot of my work on there. My faculty page is promoted on there. I'm on LinkedIn. If you like to reach out, if you need more resources, our lab does a lot of things. As a matter of fact, we are building a mobile app that would help with prostate cancer survivorship among men, African men in the diaspora and at home. So if you need more resources on that, reach out to me. My school's email address is also on my official website on there. I'm also on Instagram through my podcast called the Mosibyl Podcast. So Mosibyl. It's a podcast that's my brand name, but the podcast is called the Mosibyl because you get more out of Sibyl. You can find me at Talk to Mo, CALKTOMO at mosibyl.com, or you can check out the website www.mosibyl.com, mosibyl.com, where we share stories of Blacks, Asians, and those who love them around the world. And thank you, Ma, for having me.
And you also speak Korean language.
Hi, sister.
Thank you for tuning in to this episode of Pansa Pansa Live Podcast. We hope to have you back with us in the next episode as we continue to explore the nuances of the African immigrant experience. If you'd like to connect with us, you can email us at talk@pansapansa.org. That is talk@pansapansa.org. And follow us on Instagram at pansa.pansaforum. Until next time, remember to spread kindness and love. Thank you and take care of yourselves.